morning, everyone. Welcome to the second session of our Opioid Prescribing and Overdose Prevention Learning Collaborative. I'm Christine Lamb, a Quality Improvement Advisor for Superior Health Quality Alliance, or Superior Health. Superior Health provides support for healthcare organizations in Minnesota, Wisconsin, and Michigan under a federal grant from the Centers for Medicare and Medicaid Services, or CMS. Today's session will focus on recommendations 1 and 2 from the CDC's updated 2022 Clinical Practice Guidelines for Prescribing Opioids for Pain, which address determining whether or not to initiate opioids for pain by exploring potential alternatives to opioids for pain management. After today, there are 4 more 30-minute sessions where we will discuss the CDC's recommended prescribing practices 3 through 12. Superior Health developed an opioid prescribing and overdose prevention toolkit to complement these sessions, and we will be putting that link in chat a little bit later. Don Glover, who is also with us today, introduced us to that toolkit in session 1. Before we get started, if you would please add your name, your organization, and role into the chat, as well as any others that may be in the room with you here, so we have an idea of who's here with us today. I'm joined by my colleague, Yvonne Burston, who is also a Quality Improvement Advisor at Superior Health. She will be handling questions or comments in our chat, as well as providing links to various materials throughout the session. Just a few housekeeping items. We will have 3 polling questions during today's session and a brief survey at the end of the session. If you have a question that you would like to ask verbally instead of in the chat, just raise your hand and we'll be happy to take you off mute. Dr. Dibble is our speaker today. So Dr. Dibble, take it away.
Thank you so much, Christine. My name is Rachel Dibble. I am by trade a nurse practitioner in many areas of medicine. So today we will be discussing opioid prescribing and our learning collaborative. Again, this is session 2, and determining whether or not to initiate opioids for pain. Next slide, please. So our objectives today are evaluate and assess the patient's prior medical history and medications, understand the pharmaceutical and non-pharmaceutical treatments for pain, and determine if the patient needs pharmaceutical versus non-pharmaceutical interventions. Next slide, please. So we'll begin with the CDC Recommendation One. As we discussed before, there's 12 recommendations, and today we're discussing 2 of them, and then the subsequent recommendations will follow. So non-opioid therapies are at least as effective as opioids for many common types of acute pain. So maximize use of non-pharmacological and non-opioid pharmacologic therapies as appropriate for specific condition and patient. So what we want to do is consider opioid therapy for acute pain if it benefits, or if we anticipate that the benefits outweigh the risks to the patient. So before prescribing opioid therapy for acute pain, discuss benefits and known risks of opioid therapy with patients. And what that simply means is, I believe in practice and from a quality perspective for the patient, it's really having a discussion with them we can do this non-pharmacological and see what works, or prescribe opioids. And the patient may have a different perspective on their pain. And I want to keep in mind, when I look at pain as a clinician, I look at it from head to toe. So I don't forget about the psychological pain, which can manifest itself into physical pain. So that is something to really keep in mind to determine really what kind of pain are we looking at and what are our options discussed with the patient. Next slide, please. So recommendation number 2, non-opioid therapies are preferred for subacute and chronic pain. So maximizing the use of non-pharmacological and non-opioid pharmacologic therapies as appropriate for patient conditions. So initiating opioid therapy if expected benefits for pain and function are anticipated to outweigh risks to the patient. So before starting opioid therapy for subacute or chronic pain, we need to talk with the patients about benefits and known risks of opioid therapies, which we will get on further into the discussion so we can really determine what that looks like, and work with patients to establish treatment goals for pain and function. So we also need to consider how opioid therapy will be discontinued if benefits do not outweigh the risks. Next slide, please. So the CDC recommendations on 1 and 2. So the real big takeaway here is to determine whether or not to prescribe or refer back to non-pharm agents or therapies to mitigate pain. So what we want to do is determine the possibility. So it's the possibility. It's not saying do not prescribe. And I want to touch on that because, as we know, DEA is really crunching down on providers. So we really have to be thoughtful about dosages, about the timing of it, and tapering if we do decide on opioid therapy. So this by no means is do not prescribe, but rather it is more of the options and what can we do to mitigate some of the pain or all of the pain. So again, determine the possibilities use of non-opioid therapies that potentially are as effective as opioids for acute pain and chronic pain. Evaluate the patient's symptoms, confirm the diagnoses. That will really guide you in what kind of pain we're looking at as well. And work with the patients to establish specific and measurable treatment goals. I think that is also a very big takeaway. What is their expectation with pain? So if they have mets to the bone with cancer, their expectation may be, I want no pain. Well, that may not be realistic. So that comes from the provider to educate them on this is what your clinical picture looks like clinically, but emotionally, depression is huge. Anxiety with these huge diagnoses. So again, really evaluating the origin of the pain. Next slide, please. So here is the statistical trends of opioid overdose related to deaths. And I like statistics because we hear it in the news, we hear it in literature about overdose and opioids. So in that, you can really see the trend of from 1999 to 2019. The data is not out yet for the past couple of years, but the increase is staggering to me. So we can see all drugs, and then we can see in the black, and then in green, any opioids. And then we also have to remember the synthetic opioids, other than methadone. And then heroin is popping back up as well as obviously a major contraindication. And that is one of the reasons why overdose deaths have really skyrocketed, if you look probably from 2009 on. Next slide, please. So trends of opioid overdose related to deaths continued from the last slide. It's a little bit more specific insofar as total and female versus male. So if you see that the females actually are above the males, and then we can also see that in 2015, which isn't, from 2021 to 2015, 6 years, we've almost doubled in the amount of opioid overdose related to death. So I think this is a really good visual to see how the trends are really going up at very high rates. Next slide, please. So the statistical trends again on opioid overdose related to death, and I'm talking about this a lot because the numbers again are are really on the rise. So what we have seen as a whole from the HHS is 70,630 patients or people have died from drug overdose simply in 2019. 1.6 million have had an opioid disorder in the past year, so that really goes back to your medical history. I would also lean on any kind of maybe illicit or non-illicit opioids and other drugs that may be associated with this to really dig down in that history. It could be very touchy subjects for some patients, but the takeaway is we want to keep them safe. 745,000 people used heroin. So there we get the heroin is a big factor in here, and it will be sometimes very difficult to get patients to talk to you about this issue being in a punitive way, and it's not. It really is to keep the patient safe. 48,006 so deaths have been attributed to overdosing on synthetic opioids other than methadone. 10.1 people misused their prescription in the last year. Again, not punitive at all. When I look at the geriatric population in particular, oftentimes they don't remember they have taken it. So again, this could be a situation where it was unintentional or intentional. We have 2 million people who have used methamphetamines in the past year, and 50,000 people, again, have used heroin for the first time. So this, again, is a point to really think about as providers. 14,480 deaths attributed to overdosing on heroin. So we have it mentioned 3 times because it's really coming up, particularly in the statistics. Next slide, please. So what can we do related to opioid overdose, related to deaths? Naloxone. Big push for naloxone. Some states have it to where they have to prescribe naloxone. Those in nursing homes in particular, having this in your e-kit is extraordinarily important. But what we're looking at from the data from the HHS.gov is less than 10% of people who need such treatment are receiving it, meaning it's not being prescribed. And the guidelines are really going towards, if you prescribe an opioid, you prescribe naloxone. And then education with the patient, patient advocate, family, caregivers to understand what a potential overdose looks like, and then to give naloxone. So naloxone prevents death from an opioid overdose if administered in time. So that's really the key, to be astute of what is happening with the patient and be able to think, okay, this could be opioid. If it is not, it still does not hurt the patient to administer naloxone if you're not sure. Next slide, please. So knowledge check. How many people die each year from opioid overdose? A, 60,400, B, 100,433, C, 70,630, or D, 75,390. And we will put the poll up here.
Yvonne, you got the poll coming?
Did it show up? I put it in.
I have it, yes.
Oh, okay.
Can anyone? Oh, yeah, they're answering. Okay, it looks like they stopped, so I'm gonna go ahead and end the poll so we can see the results. Okay. Can you all see the results?
Can't.
Can you see it, Rachel?
I can.
So it looks like the 70D is what most people answered.
Right, and it's actually C. So we're at 70,630. Again, just the point there is a broad, big number. Okay, next slide. So the idea of what is pain, I believe we're all versed on pain. But again, we need to differentiate, is this acute versus chronic? So acute pain is caused by injury, surgery, illness, trauma, or painful medical procedures. It serves as a warning of disease or a threat to the body. It generally lasts for a short period of time and usually disappears when the underlying cause has been treated or has healed, versus chronic pain, which lasts 3 months or more and can be used by or can be caused by a disease or condition, injury, medical treatment, inflammation, or even an unknown reason or etiology. So acute pain, again, this is a hip replacement, back surgery. Sometimes that can go back into chronic pain. So again, in the acute world, we need to look at non-pharm, we need to look at pharmacological, we need to have a length of it, a correct dosage, and then a taper plan. Chronic pain, neuropathy could be a big one, degenerative spine disease, arthritis, etc. But going through the stepwise approach of what is appropriate for that chronic pain is paramount so that we don't over-medicate or we don't give a opioid when unneeded. And again, that's talking to the patient. What kind of pain are you having? How long has it been? What is the character? What is the location? And you might find that something else is going on. For example, left lower quadrant pain. That could be diverticulitis, for example, and it can come on quickly, and if not treated, it could go into potentially or are viewed as chronic pain when really there's an underlying reason for it. So again, listening to the patient, when did it start? When is it better? When is it worse? That will help you differentiate chronic versus acute. Next slide, please. So there are millions of pain assessments out there. I feel that the pain assessment, the Wong-Baker Faces pain rating scale, which I'm sure everyone has seen 1,000 times, I think this is a great tool, particularly culturally, or people who cannot speak English, geriatric population in particular, or someone who cannot speak, maybe they've had a stroke, and that can really go for any age. So what we want to do is on 0 to 10, 0 means no pain, and so they can point, and that will help the provider as well. 5 to 10 means moderate pain or the worst pain possible. You can also see this within your patient. So if a patient has a 10, they're not medicated and they're, jumping up and down and all sorts of things, then, it's not to question their pain. Their pain is real. It's to dig down into their pain. Where is it? How long? Character, positional could be. So it's a 10 when I turn to my side, but they may just say 10 all the time. So again, digging down into that. Guarding, grimacing, someone who can't speak in full sentences maybe is not short of breath, it is pain. So again, that really helps you to look at the history and dig down deep with some critical thinking of the etiology of pain and listening to your patient. Next slide, please. So what are non-opioid medications? So here's the definition provided by the CDC. So non-opioid drugs include serotonin and norepinephrine reuptake inhibitor, or SNRIs, antidepressants, preglobulin or gabapentin, non-steroidal anti-inflammatory drugs, or NSAIDs, are associated with small to moderate improvements in chronic pain and function. So that may be more appropriate for that person who has, say, a 3 to 5 or 2 to 5, 1 to 5 pain. I want to just preface this slide with, insofar as SNRIs, not to throw drugs into this talk, but one drug that I've been very successful with in this is Cymbalta. It does, the literature states that it does assist with pain, also depression, anxiety. So it's kind of a one-stop shop if it works. You need to look at all the other medicines, make sure there's no contraindications there. And then NSAIDs. We have to look at kidney function to make sure that we can give NSAIDs. Plavix, for example, Eliquis, Coumadin. Those are all contraindications of NSAIDs. So again, going back to that medical history, ensuring the patient is safe. GI bleeds I'll throw in there as well. That could be a major risk factor for creating another problem if the patient has, for example, had multiple GI bleeds and on blood thinners, or antiplatelets. So we need to really look at that. 81 milligrams aspirin, okay, 325, you need to, again, look at that history. Next slide.
Great. I just want to give a quick time check. Rachel, we got about 7 minutes to go.
Yeah. So what are non-pharm treatments? These work well if your pain is in that area of, say, 0 to 5 or 1 to 5. Companionship, again, addressing the depression, anxiety, etc. Exercise, heat and cold, massage therapy, meditation, music, art, or drama. Therapy, I'll throw in there pet therapy as well, has very much assisted a lot of my patients in particular. Pastoral counseling, positioning, individual counseling, family counseling, group counseling, and neurostimulation. PT, OT, aquatherapy, tone and strengthening that can really, really help with, I would say, mild to moderate pain. Desensitization, psychosocial therapy, therapy and counseling. TENS units also have been found to help, particularly with knee pain and back pain. Acupressure, acupuncture, and yoga. Next slide, please. So the benefits of non-pharm treatments are minimal side effects. We can easily combine some treatments. For example, if you can give an NSAID, maybe couple it with PT to get stronger, weight-bearing exercises as well. So we want to do is mitigate usage of opioids in pain if it is not extreme per the Wong-Baker FACES scale, and verbal responses from the patient when appropriate. Reduce potential addiction to medications. Again, look at that history if there has been an issue in the past. Talk to your patient. Again, very, very important so that we don't unintentionally, where they have a risk of overdose. Next slide, please. So why are opioids high-risk drugs? We know that respiratory depression is a big one here, particularly if they have COPD, emphysema, any pulmonary issues as well. Myasthenia gravis is a big one here. Polypharmacy. 9 times out of 10, when there's an issue, it's because the meds have not been checked in detail. Also ask the patient, because we know med recs aren't always correct, particularly in and out of the hospital. Falls, really big risk factor. Confusion, sedation, constipation, overdose, and then the security of medications and disposal of medications. I'm going to highlight constipation here for a moment. Opioids and a bowel regimen is extraordinarily important. As we know, opioids slow down peristalsis, and then an obstruction can occur. And if that obstruction perforates, then we've created a bigger problem. So really double check that. That is a guideline, but I will say in my clinical practice, it's often missed. Next slide, please. So what are the pharmaceutical treatments? I present this slide just so that you can see the hierarchy of the potency related to morphine. So if you see at the top, it trends down to where obviously you have fentanyl being the most potent. So really, really think about when you're prescribing, go low and go slow. Instead of starting out, say, with the morphine or starting out with the fentanyl. There are situations, palliative care, hospice, mets to the bone, cancers, which, that's a different situation, but just be mindful of the hierarchy of these meds. Next slide, please. So here's a knowledge check. What are the contraindications for prescribing NSAIDs and Tylenol? I'm actually not going to poll this. I'll tell you the answer because of our time. So normal kidney function and liver function, elevated kidney function, fatty liver with elevated liver function, patients on an anti-coag. So the contraindications here would be B, C, and D, particularly with the Tylenol that covers the liver, NSAIDs cover the kidneys. And then you have your anti-coag therapy as well. So again, be very mindful. Next slide, please. So before prescribing, here's the stepwise approach that I've discussed in the prior slides. Assess and evaluate patient pain. Again, head-to-toe assessment. Consider non-opioid therapies. Evaluate and inform patient of the risks and benefits. Very important highlight. Establish a very specific treatment plan. Screen for substance use disorder. Again, not punitive. It's about keeping the patient safe. Consider red flags, which the next slide talks about. Prescription drug monitoring program. Please look at your PMMD. They don't cross states. So talking to the patient again about maybe you've been prescribed something in Kentucky, you don't have access, but in Tennessee you do. So again, doing due diligence here. Schedule follow-up appointment in 1 to 4 weeks. Next slide, please. So when prescribing, determine with the patient the dosage, duration, formulations, contraindications, and side effects. Timeline of treatment using opioids. That gives you a good time to then be able to say, hey, in 7 days, I'm gonna start tapering you. Red flags to consider when prescribing. Substance use disorder, addiction, and overdose history, extremely important. Next slide, please. What are red flags? So these are things, again, to keep top of mind. So patient self-report medical history is not verifiable. Patient fails to comply with non-opioid treatments or referrals. And they have a history of dependence, overdoses, illegal drug use, prescription drug use for non-medical reasons, mental illness, sleep disorder, and their breathing, sleep apnea. They take more pills than prescribed. Patient is out of state, fails urine or tox screenings. Patient requests high-value street value medications, medications by name, increased quality or strength of opioid, early refills. Cash is being used. Patient reports lost or stolen prescriptions. More than one person at the time address receives the same opioid prescription, and patient reports financial stressors. Next slide, please. So again, substance use.
Rachel, I'm sorry. We are at time, so I don't know if anyone needs to drop off. We're going to have this session recorded. We'll get it out to you. But if you can stay on, we would love for you to stay on while we continue. Thank you so much.
And there's about 3 more minutes, just so you know. So before prescribing, again, substance use disorders are top of mind. Refer to substance use treatment. Consider referring to pain management specialists. And consider treating with the medication-assisted treatment program, which is MAT. Next slide, please. Again, review for any substance disorder. Another tool is the Beers criteria for your geriatric population to compare and contrast contraindications, what is appropriate, what is not appropriate. Side effects of opioids, determine with the patient the use of opioid therapy and opioids versus non. Evaluate goals of the patient, very specific measurable goals of the patient. Next slide, please. So the goals here in non-pharm therapy, again, we have to measure the pain. We have to see if it's decreased. We have to see if they're able to tolerate. We have to be able to see if we've mitigated some pain, improve functional and quality of life, reduce the risk associated with opioid pain therapy. And for non-pharm, Patient reports 3 days after PT, the patient's pain has decreased from 5 to 3 on a scale of 1 to 10. And that was an example with physical therapy. Next slide, please. Knowledge check. So what medications will reverse an overdose? I'm gonna go ahead and give you this answer because of time, and that is naloxone. So again, keep that really in the forefront of your mind when prescribing. Next slide, please. Takeaways. Again, medical history. Patient is the center of the care plan. Compare risks and benefits of opioid prescribing, non-pharm therapy or over-the-counter drugs. Look at your red flags. Prescribe low and slow. Naloxone, again, ensure they have it, and monitor through their journey of opioids or not. Next slide, please. So, does anyone have any questions for me? Happy to answer, just put in the chat. Coupled with the evaluation, if you all would take a minute as well, and give you about a minute or so to complete that. So just let me know any questions here.
So Rachel, I think you had the link to the CDC guidelines on one of your slides, right? So if people want to read a little bit more in depth on these guidelines, they can click on that.
And the toolkit is very, very helpful with this.
Right. Oh, right. Yvonne, do we have the toolkit link? Yeah, Yvonne, just put the toolkit.
Yeah, just put it in.
Okay. Oh, that's the registration link, I think, isn't it?
No, that one is the toolkit. Wait, let me double check it just to make sure. That's the short toolkit.
Oh, I see John's got some shine a light on stigma information here. You go to Superior Health Quality Alliance or superiorhealthqa.org. You make a pledge to shine a light on stigma.
Yeah, that's the toolkit. And we wanted to also put the PowerPoint from last week just in case anyone missed it.
So here are our upcoming sessions. We do have a link here if you need to register for the 4 more that are coming up to go through the CDC guideline or recommendations 3 through 12. And then on the slide is Superior Health Connect link. If you haven't joined already, please do so. Connect is used as a platform to share information and continue conversation on a variety of healthcare topics. This concludes our presentation. And if there are any final questions before we sign off, we can take those. Otherwise, we wish you a good day and thank you for joining us. And we'll see you next time.